Hi everyone, this is Dr. Saiti, team INBDE CONQUER. So today's discussion is on patient box. Okay, so wherein in your INBDE exam we have come across the clinical scenarios or case-based questions are being presented in a form of a patient box. Okay, so in that box they give the details of the patient, they give the background history, they give the chief complaint as well as the clinical findings. So at times they also post the picture clinically or radiographically, which will help us to arrive at the diagnosis. Okay, so how these questions are being asked is, as I said, it's in the form of a case that is presented in the form of a box, followed by the question and the options, and you have to go for the correct answer. So today I'm going to discuss few important cases from your oral medicine, oral pathology, and wherever required, the radiograph is also included because at times the radiographic features actually help us to arrive at the correct diagnosis, right? So radiograph is also required wherever the question has its need. Okay, so like that, few questions I'm going to discuss so that you'll have an idea and also you'll have that practice before arriving for your exam. Okay, so coming to the very first question. So as if here you can see here, so it's a patient data of a 14-year-old female. So this girl is a 14-year-old female. So now you have to be very sure of each and every line that is presented in this box. Okay, so the chief complaint here is that she has to correct her crooked teeth. Okay, so next, the background history. It's quite important because here the history says that the family has, the mom and dad had a consanguineous marriage. Okay, so wherever, I mean, it's not always, but consanguineous marriage cases might have a genetic, like genetic abnormality in the offspring. Might have chances, might be there. So that's the reason here the background history definitely has its importance. And a very, very important, which actually help us to arrive at the diagnosis, are the 3 points that are being given here. So these are the clinical findings or the key points which will actually exactly arrive us at the diagnosis, right? So here, what are those clinical findings that is being given in the question is the micrognathia, cleft palate, and the glossoptosis. So here, if you see the girl, obviously you can appreciate the micrognathia, right? So, and in the question, it's clearly mentioned the triad, that is micrognathia, cleft palate, and glossoptosis. So I think by now the answer must have been clicked, but let's see the option. So what is the syndrome that you can diagnose in this patient is the question. So there are 4 options, that is Treacher Collin, Peutz, jegher, and Romberg. So we know in Peary-Robin syndrome, you see this sequence, you see this triad, right? So happily you can go for the answer of Peary-Robin syndrome and you can eliminate the others if you know the findings of the other options also. But here it is a straightforward question, that's a Peary-Robin syndrome. So what exactly happens in a Peary-Robin syndrome? It's a sequence, okay? So patient will be having a hypoplastic mandible, because of which a secondary enamel like the tongue will fall backwards and glossoptosis occur, and the tongue will also obstruct the palatal fusion, and there will be a U-shaped palate and a cleft palate occurs. Okay, so these are the very important sequence. So that is micrognathia, glossoptosis, and cleft palate. So this is a sequence, or this is an important triad of a Peary-Robin syndrome. Okay, so I hope you got an idea of how the question can be asked in respect to the important diseases or the important syndromes from your subjects in your exam. Okay, so this is the very first question. Now let's go to the next question. So here again you have seen a data. It's a 53-year-old female, and the chief complainant, she has a swelling of the upper lip, as you can see. That's since a very long time. That's a chief complaint. And the patient has developed swelling of the upper lip, and also there's a drooling of saliva in the corner of the mouth. So that is a history. Now coming to the clinical findings, where we have to check for the key points. Okay, so she's unable to smile on the same side. There's absence of wrinkles on the forehead, and intraorally fissured tongue is there, as you can see. So in the background history also, you have seen that there is a drooling of saliva from the right corner of the mouth. And in the clinical findings, you have seen that she is unable to smile on the same side, absence of wrinkles. So all these will help us to arrive at one of the component of a syndrome, which is nothing but a facial palsy, right? So there is a paralysis of the facial nerve. So this is that. Next, fissure tongue is clearly given, and there is a picture showing the fissure tongue. This is a second component. Third component, if you see, the swelling, right? So what exact swelling of the upper lip? So there are 3 components now: the swelling of the upper lip, the facial palsy, and fissure tongue. So we know out of this we have got the 3 important key points, right? Now let's see the options. So what is the condition? So P.D. Romberg, McCune Albright, the cheilitic granulars, and Ramsay Hunt are the options given. So where do you see these three components? That is fissure tongue, the facial palsy, and the upper lip swelling, which is nothing but cheilitis granulomatosa. So where do you see that? So if you go through your developmental disturbances chapter from your oral pathology in your Schaefer, these three components are seen in our McCune-Rosenthal syndrome. Okay, so you see fissure tongue, you see facial palsy. So here the patient had that all the features of the facial palsy, like absence of wrinkles, unable to smile, drooling of saliva. So these are like arriving us for the facial palsy. Obviously, fissure tongue is also, the clinical picture of the fissure tongue is also posted. Next, the swelling of the upper lip, which is nothing but cheilitis granulomatosa. So these three are the components of the McCune-Rosenthal syndrome. That's all. Okay, so we know that disease, we know the components, but how it is being presented in the exam and how we need to get exposed is the main thing that we have to do now. That's all. Okay, so next, coming to the next question. So here is a 65-year-old man who is living in so-and-so place in southeast of Iran. Okay, and the chief complaint is he has fever, cough, chill, shortness of breath. So these are like respiratory symptoms, as you can see. And then the background history, like, has history of keeping animals. Okay, so that is why they have given in history. Maybe it has some importance. And also like sheep and goats, but animals were not infected. And he has a long history of COPD also. And the symptoms didn't like improve despite of antibiotics. And the patient was referred to the hospital. Okay, and here is the radiograph that is there. Okay, now we'll see the current findings, so the clinical findings. So here the chest x-ray has shown a mediastinal widening. It's clearly shown. Pleural effusions are there, parenchymal infiltrations and lymphadenopathy is there. And the blood samples are revealed gram-positive streptobacilli with a bamboo stick appearance. So that appearance might have an importance again. So that's a key point again. And the blood culture has shown a creamy coarse grayish texture with irregular border lines with hemolysis looking like a jellyfish. So all these now if you see, so how to think. So now after seeing this question, one thing is clear that this is an infectious disease for sure. Okay, because there are fever and there is lymphadenopathy and all those pulmonary symptoms are there. So it's infectious. That is understood, right? Next, in the background, he is having a history of animals and all that. Okay. And in the current findings, that is the chest x-ray, if you see, or the chest radiograph, what you have observed, there's a mediastinal widening, which is a very important key point. Okay. And then a culture is taken and there's a bamboo stick appearance. So this is a combination of oral path as well as a microbiology. Okay. So this bamboo stick appearance you see in a bacteria. Okay, already it is given as a gram-positive streptobacillus. So already it is very clear that it's a bacterial infection again. Okay, so now let's go for the options and let's arrive at the answer. Okay, so identify the disease. So it is wool sorters, pulmonary anthrax, tetanus is the options that is given, and fourth option is both A and B. So now it can't be tetanus because in tetanus we definitely see that, rigidity, the log jaw, rigid muscles and all that, right? So this can't be tetanus. So other option could be, since it's a gram-positive bacilli showing a, that bamboo stick appearance, it's nothing but a Bacillus anthracis caused disease, which is our anthrax. So it is a pulmonary anthrax. So there's a mediastinal widening is a very, very important radiographic feature seen in the chest radiograph of whoever is suffering from pulmonary anthrax. Okay. So it is caused by this bacteria, that is Bacillus anthracis, and in a microbiological view, it is showing the bamboo stick appearance. So all these are the key points to arrive at the pulmonary anthrax option. But there's one more thing that is being given, that is a wool sorter's disease, right? So wool sorter is other name for pulmonary anthrax. Okay, so wool sorter disease is other name for pulmonary anthrax. So here both A and B are your answers. Okay, yes. Now coming to the next. A 25-year-old female has come for the regular dental checkup. There is no particular history over there. But as you can see, there is a serpentous pattern in the observed on the tongue. Now what is that? Simple. It is showing a serpentous pattern of depapillated tongue. So it's a case of a geographic tongue. That's all. It's a case of geographic tongue. which is also called as benign migratory glossitis or erythema migrans. So answer here it is both A and B. So for the previous question also, the Wool-Sorter's disease, which is other name for pulmonary anthrax. So even there it is both A and B. And even here also it is geographic tongue, because you have seen the serpentine borders on the tongue, and erythema migrans. So both A and B is the answer. Simple. This is a very simple question, right? Next. Here, a patient has, like it's a 20-year-old female, regular dental checkup, and hyperplasia of the cingulum of the anterior teeth is seen. So it's a developmental anomaly of the tooth. Simple question. I think you can guess this. It's just a cingulum that is hyperplastic, and you can see that cone shape. So what is that? So identify whether it's Talon's cusp or enamel hyperplasia, Turner's, or options among the options. It's a straightforward question. It's a beautiful picture is also posted. So it is hyperplasia seen on the cingulum of the teeth. So it's nothing but the Talon's cusp. So now my question is, name a syndrome which is related to the Talon's cusp. So from your Schaefer, if you see the syndrome which is associated or where you see the Talon's cusp is a Rubinstein-Taybi syndrome. Okay, it's a Rubinstein-Taybi syndrome. Okay, good. So yes, let's go with the next question here. So here it is a male of a 10-year-old. Okay, and he has cavities in the mouth and reddish rashes on the hands and feet. That's his chief complaint. And he was born to a mother who has poor prenatal care and belonged to a less socioeconomic group. Okay, and then the clinical findings. So what are the clinical findings? So there's a diffuse erythematous palmoplantar keratoderma along with desquamation and fissures, and intraorally we have seen dwarfed molars, as you can see in the picture, and also there are screwdriver shaped incisors. So all these can be nicely appreciated in the picture that is given, right? So very nice question, to be honest, because you have seen a direct the important or a characteristic feature of a disease where you see the mulberry molars and the screwdriver shaped incisors. These are nothing but Hutchinson's teeth. Okay, so there is a triad which is called as an Hutchinson's triad, where you see the screwdriver shaped incisors, mulberry molars, interstitial keratitis, and eighth nerve deafness. Right, so all these are the features or the triad that our Hutchinson's triad is seen with. Very good. It's congenital syphilis, right? So it's nothing but a case of congenital syphilis. So as you can also see a rash, besides that, the intraoral findings are these. So obviously the question is helping us to think of congenital syphilis. But yes, before going for the other thing, we have to definitely read all the options and what is exactly the question being asked, we have to think, right? So what is the question now? So what are the other findings that can be expected in this child? So here they are not asking us to diagnose. They are asking what are the other findings that can be seen in this disease or in this condition. So obviously we have arrived at a diagnosis that it could be like it is definitely because there's a Hutchinson's teeth there. So it is a Hutchinson's triad it is component of Hutchinson's triad, that is screwdriver shaped incisors and mulberry molars. So obviously we know that it is a case of congenital syphilis. Right? So it is a very clear-cut case of congenital syphilis. Now, what are the other findings that will be expected in this child? So a scapula in the vertebral border below the level of the spine is having concavity instead of convexity. Yes, this can be expected because this is nothing but scaphoid scapulae. Scaphoid scapula. So this is a finding that is seen in congenital syphilis kids or children affected with congenital syphilis. So this is a scaphoid scapula. Next, anterior bowing of the mid portion of the tibia. Yes, this is nothing but Schäber shin. Okay, this is nothing but Schäber shin. Even this you can expect in this child. Okay. Next, thickening of sternoclavicular portion of the clavicle. Yes, this is Higo-Menakes sign. Higo-Menakes sign. Higo-Menakes sign. So scaphoid scapula, Schäber shin, Higo-Menakes sign, saddle nose, okay, regades of lip. All these are the very, very important features of congenital syphilis. Besides our Hutchinson's triad, these are the very important features of congenital syphilis. Obviously, our answer is any of the above, right? So this is how the questions can be put forward. Either they'll ask you to arrive at a diagnosis, or they will ask you to give other findings, or they'll ask you to give an investigation. The question can be asked here this way or that way. The only thing is you need to get exposed to those type of questions and you need practice. That's all. Okay. So next, the other question now. Here is a 30-year-old female pregnant patient. So she was having fever, dry irritating cough and growth on the tongue. This is a growth on the tongue as you can observe. And the patient was having a bacterial pneumonia a few weeks back. So this is also an important point. Now coming to the clinical findings. So there is a nodular ulcer with undermining edges. So this is a key point. Always focus on the key points given. So there is an ulcer with undermining edges. So that is a key point. And dorsum of the tongue and canker sores and intraorally was there. And cardiopulmonary examination has shown V's with scattered crackles as you can see here and there, especially in the upper two-thirds of the tongue. And a radiograph has shown radio opacities throughout the lung fields in the upper two-thirds of the tongue. And there was a granulomatous inflammatory process. So this is a granulomatous infection, obviously, undermining edges, involvement of the lungs. This is nothing but a case of, just think, before that we'll arrive at the answers or the options. So what is the diagnosis now? So there's squamous cell carcinoma, no. It will have an everted edges, so no. Canker, it will be painless and it is seen in syphilis and lung involvement may not be much. Tuberculous ulcer with pulmonary involvement. Yes, here's the pulmonary involvement is there. You have seen radio opacities, the gone focus that you see in the tuberculosis. Besides that, the very important key point intraorally is the undermining edges of the ulcer. So these two are the thing, and granulomatous obviously. So all these are the key points which are helping us to give a provisional diagnosis of tuberculous ulcer with a pulmonary involvement. Why is it not final diagnosis? Because before doing, you have to go for the acid-fast bacilli. You have to do a Montauk's test to go for the final diagnosis. This is just a provisional diagnosis based on the key points of the clinical or the current findings and the history that is given by this patient in the box that I have presented. Okay. So geotrichosis, no, because it will be like a patch. So obviously the straightforward answer for the options given in this particular question where you can think of the provisional diagnosis of tuberculous ulcer. Obviously, there's a pulmonary involvement, there is fever, there is all these features that is there is helping us to arrive at the answer. There is a bacterial pneumonia, right? So it's a straightforward answer. That is tuberculous ulcer with pulmonary involvement. Good. Next question now. So it's a 11-year-old girl. She wants a correct alignment of her teeth, consanguineous marriage of the parents. So whenever there is consanguineous marriage, you can think of some genetic abnormality in that offspring. Next, what are the clinical findings? So there's a mandibulofacial dysostosis, wide face, hypoplastic maxilla, hypertelorism, bulging of eyes as you can see, prognathism of the mandible as you can see. And the radiograph here, it is showing something which is very important. Okay, so there is a radiographic picture. Obviously, it's a syndrome that we know. All the syndromic features are there, right? But the radiograph is showing some very good characteristic feature here. So what is that now? So it is nothing but a copper beaten skull or a hammer beaten or a metal beaten skull. Okay, so this is a syndrome where you see the copper beaten skull is the, let's see the options now. It's not a.Apert syndrome because in a.Apert syndrome, most very important feature is the socket feet and the mitten hands that is syndactyly. Obviously, the other features could be there, but that is not presented here, so it is not that. Robin, as we have already discussed, that it will have micrognathia, glossoptosis and cleft palate, so it is not that. Treacher Collin syndrome, the patients will have hypoplasia of the malar bones, it is not that. The copper beaten skull, along with the characteristic features that is given here, it is nothing but a Krausen syndrome. So the copper beaten skull, the radiographic feature, the radiographic picture that is given, it is a straightforward case of Krausen syndrome. No need to think of other options also. The copper beaten skull, hammer beaten skull, metin beaten skull, it is clearly seen in this syndrome, that is Krausen syndrome. Okay, so that here in this particular question, though the clinical findings, history, everything is important, but the most important thing is our radiographic picture that is posted. Okay, so this is a case of Krausen syndrome. Next question, the main thing of the Krausen syndrome. So here it is characterized by primarily closure of the fibrous joints the cranial sutures between the certain portions of the bone. So there is craniosynostosis and distinctive facial abnormalities is also there. So that is a primary characteristic of the Clausen syndrome. Okay. So next question now. So here it is a 3-year-old girl, regular pediatric checkup, consanguineous marriage, so genetic abnormality. So there's a depressed nasal bridge. So the nasal bridge is gone. Propoptosis of eye, hypertelorism, maxillary hypoplasia, mitten hands and socket feet. Just now I have told in the options in the previous question. Okay, so this is our key point. Obviously the depressed nasal bridge is also our key point. So now what's the condition here? So let's eliminate. Clausen syndrome, no, because the nasal bridge will not be that depressed. It will have a good nasal bridge only, and obviously syndactyly won't be there. Hypertelorism, all the other features could be there. Okay, so it's not that. Cherubism, it will be like chubby cheeks. So it's not that. McCune Albright, you'll have the cephaloid spots and all that, and precocious puberty. So it's not that. So obviously it is a.Apert syndrome. So in a.Apert syndrome, you see that syndactyly. Okay, so where you see the mitten hands and the socket feet. So it's a very, very, very important feature of the kids or the children suffering with a.Apert syndrome. Okay, so what does it have similarity with the Clausen's is? So brachiocephaly, hypoplastic mid-face, hypertelorism, proptosis, all this could be there. And common radiographic, yes, impacted teeth, delayed eruption and ectopic, eruption, supernumerary teeth, calcification of styloid process could be there. And distinguishing from Clausen is neurological deficits, syndactyly, as you can see here, the fusion, and also the fusion of cervical vertebrae. So all these are the differentiating features. So here in this particular baby, since we have seen the mitten hands and socket feet, so that is a very important key point for us to arrive at the a.Apert syndrome. Similarly, the previous question, the very important feature was the radiographic feature of a copper-beaten skull, which is arriving at the Clausen syndrome. Okay, so just note the differences between the Clausen versus a.Apert syndrome. Okay. So now here you can see an 18-year-old male. What is the chief complaint? So it's a complaining of discolored teeth since his childhood. The background history that he shares that there was like bluish discoloration of the milk teeth. Okay, and he underwent crowding of the upper incisors 2 years back. And what are the clinical features? So there's a bluish amber colored teeth with a translucent hue. Okay, very important finding. Bluish hue, translucent hue. So that is a key point. And OPG revealed obliterated pulp chambers, as you can see. So here you can see the translucent hue in the teeth, and you can also see that pulp chamber obliteration. Okay, so what it could be? Let's see for the question now. So this is our patient box. What are the key points? Bluish amber color, translucent hue, and obliterated pulp chambers. So which type of collagen is affected in this disease? So now first, where do you see the bluish hue on the teeth and the pulp chambers is obliterated? So which disease you can think of? Okay, so this is a case of obviously the Dentinogenesis imperfecta. So if associated with osteogenesis, you can also see the bluish hue in the sclera. Okay, and in osteogenesis imperfecta, you can see that fragile bones and all that. Why? Because there is a defect in type 1 collagen. So this type 1 collagen is present in the sclera, is present in the dentin, is present in the bone. So obviously, if osteogenesis imperfecta along with dentinogenesis or just dentinogenesis imperfecta can occur, obviously the defect is seen with the type 1 collagen. So wherever the type 1 collagen is affected, obviously the patient will show the respective clinical features. So here the patient show bluish that translucent hue of the teeth, and if the same patient also had bone fragility and brittle bones and the bluish hue of the sclera, so you can also think of osteogenesis imperfecta. So in that disease, the type 1 collagen is affected. Okay, so this is nothing but a case of osteogenesis or a dentinogenesis imperfecta where the type 1 collagen is affected. Okay, yes. Now coming to the next question. So here a 7-year-old female, crowded upper front teeth. So ophthalmic problems are there, and V pattern is there, strabismus is there, high myopia is there, cardiac problems are also there like mitral valve prolapse, aortic aneurysm. So underline that. And patient has genetic test and there's a mutation of fibrillin type 1. Okay, so very, very important key point. Within the history only we got it. Okay, and next the clinical findings. So there are elongated arms, legs, fingers, dolichocephalic head, broad forehead, and maxillary retinospathia, high arched palate, hypermobility of the joint. So here elongated arms and legs, and fibrillin type 1 genetic disorder, and aortic aneurysm. So what can you think of? Now go for the options. So what is the clinical finding based on the history and the clinical findings that is given? What is the diagnosis that you can think of? So first, McCune Albright syndrome, no, you see a cephaloid pigmentation and all that, so it's not that. Rubinstein-Taybi, no, anyways, it's not that. ALS-Donlon, of course, here you have seen little hypermobility of joint, but here in ALS-Donlon, you see hypermobility of the skin, everything. The other features of elongated hands and feet and mitral valve prolapse, the aortic aneurysms, and definitely the gene mutation of fibrillin type 1. So that is a very important key point of our Marfan syndrome. Okay, so there's clear-cut mutation that has been presented. So it's an autosomal dominant disorder where you see the type 1 fibrillin that is got mutated. Okay, so it is a case of Marfan syndrome. So in Marfan syndrome, obviously you have eye problems, you have heart problems. Okay, so abnormal chest, heart-related problems. Okay, and tall, thin body frame, and obviously the long arms and long feet and long fingers, all that are the features of the Marfan syndrome. So this is a clear-cut case of a Marfan syndrome. Okay, good. Now here, next case is 11-year-old female, missing teeth and swollen gums, and there's premature birth, delayed milestones, IQ is 35, trisomy 21, irregular sequence is there, trisomy 21. So background history, very important key point, trisomy 21. And in clinical findings, brachycephaly, slanting palpebral fissures, palmar trees, and hoarse voice. So, of course, there are many other features, but very straightforward feature or the thing that we can completely focus is nothing but our trisomy 21. So, what is our trisomy 21? What syndrome is trisomy 21? Simple. Down syndrome. No need to think of other options and eliminate also. Trisomy 21 is Down syndrome. That's all. Okay. So, here this is a simple case of Down syndrome. Clear? So, in Down syndrome, you see that all the other features that were presented. Okay. So palmar crease, all that, very important. Brush field spots in the eyes. So these are the very important key points. But yes, trisomy 21 is nothing but a genetic thing that you see with the Down syndrome. Okay, good. Now going to the other question. This is a 16-year-old female. Fluid secretion in the lower lip, it is there. History of cleft lip and cleft palate when he was a toddler. So what are the clinical findings? Mid-phase recursion is there. Lower lip, bilateral lip pits are there. So if you see the picture, lip pits are there. And congenitally missing teeth are there. Marked hyperplasia and label abrasion are there. So lip pits. So lip pits is a very important key point here. So what is the syndrome that you can think of? So what is a syndrome associated with the lip pits? Van der Wood syndrome. Okay, so the syndrome which is associated with the lip pits, the pits that is seen in the lower lip especially, is nothing but a Van der Wood syndrome. That's all. Okay, so I think it is now, you are getting more adapted and you are able to think now, right? So next is a 16-year-old boy. He says discoloration of the teeth, and family history reveals that there's presentation of the teeth which are discolored. In the family also there were some other people who had the similar discoloration. So here you have seen yellowish discoloration and radiograph. So now the radiograph is showing a very important key point. That is picket fence appearance. So this line, that is picket fence appearance, is from your white and farrow. It is not from your oral path. So this picket fence appearance is seen from your white and farrow. So now what can you think of? So now let's go for the question. So picket fence appearance, yellowish discoloration of the teeth are the two important, and also the family history are the important key points for us to think of now. Now let's see for the options. So based on the clinical and radiographic findings, what will you think of? Dentinogenesis imperfecta? No. There will be obliteration of the pulp chambers. They will not, we have never heard of this picket fence appearance. Dentin dysplasia, rootless teeth? No. So the other two. So it's hypomaturation and hypoplastic type of amelogenesis imperfecta. So it is a case of amelogenesis imperfecta, yellowish discoloration you see. So what among these two, what it could be? So in hypomaturation type, you see snow-capped teeth. Okay. So you see snow-capped teeth in hypomaturation type radiographically. Here this is a case of hypoplastic type because the enamel is lost or the enamel is not there or it's very thin, because of which there will be loss of contacts between the teeth. And especially if the anterior teeth, if you see a radiograph, you get that picket fence appearance. Okay, so radiographic finding is a very important thing for us to think of the diagnosis. So here you have seen that there is no contact, so there is less enamel. So this is a hypoplastic type of amelogenesis imperfecta. If snow capped teeth is there, then you can go for hypomaturation type. Okay, so this is from your radiology point of view. Good. Now coming to the next question. So here is a 34-year female. The pain and swelling in the floor of the mouth in the right side. So here the swelling is hard, tender and more evident on eating. And there is decrease as salivation. Okay, so there is a decrease in the salivation also. So there is a swelling here. Okay, and the swelling is hard, tender. So it is something related to salivary glands that we can think of. Okay, so what is the probable diagnosis? So here it is just a swelling and on eating it is differing. So it is simple case of silolithiasis. Okay, so it's a simple case of silolithiasis. At times you can clearly appreciate the stone in the picture also. Okay, so this is a case of silolithiasis. Now coming to the next question. Here is a 45-year-old male, chief complaint of difficulty in opening the mouth. So this is a client. Why there is a difficulty? And he has smoking and alcohol habit. Clinical findings is diffuse white lesions, as you can see in the buccal mucosa, lateral borders of the tongue and the labial mucosa, and decreased ballooning of the cheek. So the patient is not able to balloon. So there is some fibrosis there. Obviously, he's having some habits, difficulty in opening. So there is something that has occurred or some condition which can decrease that he's not able to blow, and decreased mouth opening is there. So these are the key points that you have to put in your mind. Now think of the answers. Smoker's melanosis. Melanosis means it will cause the dark pigmentation, but such type of complete rigidity and ballooning absence or the rigidity in opening will not be there. Mucosa baccarum, no. Oral hairy leukoplakia, no. It will be mostly on the lateral border of the tongue. So obviously, because of fibrosis, oral mucosal fibrosis is the case. There is blanching of the oral mucosa, there is whiteness, there is blanching, and the patient is not able to open the mouth, not able to blow. And if the further features like shrunken uvula, rigid tongue, all these are nothing but the case of oral submucosal fibrosis. That's all. Okay, so this is a case of course, a patient in the history, personal history, gutka chewing or that areca chewing is not given. But still, you can definitely think of this because of the nice features that is being presented. The blanching of the oral mucosa and the clinical findings. Among the options given, definitely you can go for oral submucosal fibrosis. Okay, yes. Now next question. Severe is 11-year-old male, kid is a kid, and severe pain in the throat and fever since 5 days. So you can see a clinical picture something. And he didn't take any antibiotics, and there's mild swelling of the neck. That's an important point. And there's a thick adherent pseudomembrane. Okay, so thick adherent pseudomembrane, fever, a kid, and swelling of the neck. So these are the 4 key points here. So what is the condition? So tetanus, it will have a locked jaw. No. Herpangina is a vesiculobullous, it's viral, it will have vesicles in the posterior tongue, not a membrane. It will have small vesicles or ulcers in the posterior part of the palate, which will not show an adherent membrane. No. Herplex simplex, definitely no. So obviously it is a case of diphtheria. So it is caused by Corynebacterium diphtheriae. So where the bull's neck, okay, what are the important features? Bull's neck, thick, adherent, pseudomembrane. Okay, thick adherent pseudomembrane. So all these are thick adherent. So it's very painful. The membrane can't be removed. It's very painful. Okay, so Corynebacterium diphtheriae, thick adherent pseudomembrane, the bull's neck are very important features of Corynebacterium diphtheriae. So here the answer is diphtheria. Okay, yeah. Next, a 21-year-old male, multiple missing teeth. What are the clinical findings that is given? Multiple missing teeth are there. Scalp hair is less. Sparse eyebrows, as you can see, and perioral pigmentation. So now think of the question and the options. So what are the findings? Missing teeth, hair is sparse. So hypotrichosis, hypodontia. 2 important points, and periorbital pigmentation also. But these 2 are the key points. Hypotrichosis, hypodontia, conical shaped teeth. So not in Romberg, not in Peri-Robin. Peri-Robin is a triad we know. So it is simple case of ectodermal dysplasia, hypertrichosis, hypodontia, okay, and also note dry skin. All that are the very important findings of ectodermal dysplasia. So here you see question says that the scalp hair is less, eyebrows are less, and obviously the cone-shaped central incisor, the missing teeth, hypodontia, all these are nothing but ectodermal dysplasia. That's all. So this is a simple case of ectodermal dysplasia. Next question. So we are at almost to the last. So this is 11-year-old girl, swelling in the right side of the face, and she has said that there's a scratch by the cat. Okay, so you can think now. So swelling is there here, as you can see, and also right eyelid also there is swelling. So the cat must have scratched like this. So it's a simple case of what now? Just think of that. So there's a swelling of the glands and the ocular region. So it is a case of a cat scratch disease. That's all. Okay, so it is also called as oculoglandular syndrome of paranoid, and obviously it is caused by Bottinella henselae. So it is both begins. It's a bacterial disease caused by Bottinella henselae and ocular glandular. So if the cat scratches this, you can see the swelling of the eyelid and the glands. So oculoglandular syndrome of the paranoid. Okay, so this is our case. Okay, so like this you have to think and answer. So you have to go for nice detailing what all is given in the patient box. You have to see for the clinical and the radiographic picture or what all findings is given, and then you have to go for the question and you have to answer. If there is a straightforward thing, you can directly arrive at the answer. If there is a confusion, you can eliminate and go. Okay, so this is how you have to get adapted to the patient box for your INBDE. Okay, thank you.